This video is intended to discuss about various abnormal head postures due to ocular causes. Nearly 1.1% of the patients presenting to the ophthalmology clinic have abnormal head postures. Abnormal head postures can be caused by ocular and non-ocular diseases. Commonest ocular causes are nystagmus, superior oblique palsy, cranial nerve palsies, lens retraction syndrome, and astigmatism. Abnormal head postures are adopted to improve visual acuity or to avoid diplopia or to obtain binocular single vision. Abnormal head postures can be a face turn to right or face turn to left, or chin elevation or chin depression, or a head tilt to right or left, or a combination of this. Abnormal head postures may be an essential clinical sign for an underlying disease. A comprehensive eye examination is a must to rule out orthopedic and neurological causes. Long-standing abnormal head postures may lead to facial asymmetry and secondary musculoskeletal changes. Hence, when strabismus is present with abnormal head postures, it's an indication for surgery in majority of the cases. In this video, this boy had significant face turned to left and the eyes are in dextroversion. This is because the child was having nystagmus in all gazes, which is getting dampened while adopting right gaze, probably the null point. In order to keep the eyes in dextroversion, the child adopts face turned to left. This is another case of face turn. Here the face is turned towards right and the eyes are in levoversion. This is a case of type 1 lens retraction syndrome, right eye with abduction limitation. So the patient will have diplopia or confusion while looking to right. So he prefers left gaze. To maintain this gaze, he adopts face turn to right. This is another case of face turn. Here face is turned towards right. This is because this patient had right LR palsy with -4 to -5 limitation of abduction in right eye. All other movements are full. In order to avoid diplopia, patient prefers the left gaze with face turned to right. On levoversion, the patient won't have diplopia. This video is showing significant chin elevation in this 8-year-old boy. We can observe there is marked exodeviation in up gaze, but exotropia is decreasing in the primary position and almost nil in down gaze. This is a case of V exotropia. Here, in order to avoid up gaze and diplopia, patient acquires a chin elevated posture. Similar to the previous case, this boy also had a chin elevation. See from the video, this patient had a ptosis in the left eye which is partially covering the pupil. Extraocular movements were full. While keeping the chin in the elevated posture, child is able to see binocularly. This is a case of congenital ptosis in left eye with chin elevation. This is the third case of chin elevation. Here one can see limitation of elevation in adduction in the right eye. This is because the child is suffering from right brown syndrome. So the patient avoids up gaze by keeping the chin in the elevated position. This is the images of two kids with right superior oblique palsy. We can observe head tilt to left side. Long-standing superior oblique palsy can lead to musculoskeletal changes and facial asymmetry as evident from the first and second images respectively. Isolated superior oblique palsy present with hypertropia of the same side and head tilt to the opposite side. This patient has got left superior oblique palsy. This video is showing hypertropia of left eye and alternate cover test showing L by R. there is significant superior oblique underaction in the left eye. On head tilt to right, hypertropia is decreasing, and on head tilt to left, hypertropia is increasing. Hence, the patient adopts right head tilt. In isolated superior oblique palsy, hypertropia will get better on opposite head tilt and get worse on opposite gaze. Thank you for watching.
Have you seen torticollis?
I have seen torticollis, but it is not here.
Yeah.
It is
You'll have to roll out.
Yes,
Roll
often
out.
case only I included in this video, madam.
Not included.
Not included.
Okay.
So there are, in some cases you have shown there's nystagmus, right?
Yes.
How and when do you advise a neuroimaging? The kind of nystagmus, how frequently do you advise?
In case of pure congenital nystagmus without any other systemic on examination, if there is no neurological association, we could see. In that cases, we won't go for if we suspect any neurological abnormality associated with nystagmus, we go for imaging. Otherwise, pure congenital nystagmus, we usually do not go for imaging, madam.
Have you tried prisms? Like nystagmus, sometimes, of course, there are surgeries for it.
This amplitude of the large amplitude nystagmus was there, and the patient was having significant chin posturing, and the deviation also was very large. So in that case, it's not good to try prisms, madam.
In the lesser frequency and small
Yes.
amplitude nystagmus, you can try the prisms. Okay, thank you. Thank you for the presentation.
Next, Dr. Soumya.